So regarding surgical management for a patient who has have a suspected, we can say surgical management is going to be for a patient who has suspected ACC, because before surgery we don't have like 100% diagnosis yet. But patient with suspected ACC should proceed with surgical management. And again, I'm going to highlight some recommendation from the Endocrine Society, European Society of Endocrine Surgeon, where they have also comprehensive guidelines regarding surgical management for ACC. I'm just going to highlight some couple of points, which is important to know. Usually the open adrenectomy is a gold standard treatment for suspected ACC. And also it's helped to establish histopathology diagnosis, which is the gold standard for diagnosis of ACC. The surgery is very important because the only cure or the only chance of cure in ACC patients without metastasis is a complete tumor resection. That's by achieving microscopic margin-free resection. For that reason, the surgery should be performed by experienced surgeon who has experience in adrenal and oncological surgery. There's some question about does open surgery or laparoscopic surgery can be done. But because of the low incidence of ACC, there's no randomized clinical trial to compare laparoscopic versus open surgery approach regarding outcome, tumor outcome. And the current knowledge is based on retrospective studies and expert opinion only. But the choice of best surgical approach is for suspected ACC should be based on both tumor size and evidence of local invasion. Usually open surgery is recommended for all tumor if there's any radiological finding of suspicious for malignancy and evidence of local invasion. Laparoscopic surgery is reasonable for some smaller tumor size less than 6 centimeter without any evidence of local invasion. But it's advisable to convert to open surgery when obvious signs of invasion are encountered during laparoscopic surgery. That would prevent complete resection. Second important point is the rule of regional lymphadenectomy. So because the recurrence of ACC is high, usually the regional lymph node involvement in ACC has a negative impact on overall survival and is frequently the cause of tumor recurrence. For that reason, they suggest that routine local regional lymphadenectomy should be performed with adrenectomy. And all suspicious or enlarged lymph nodes identified pre-op imaging or during the surgery should be removed. Regarding the need of removal of or resection of adjacent organs, they recommend that in block resection if adjacent organs are suspected to be involved. That's all true for the spleen, the pancreas, stomach, kidney, liver, diaphragm, as well as the IVC and renal vein. And the critical point of removing the tumor is very important to remove the tumor and to keep the capsule of the tumor intact. Because if there's any damage to the capsule of the tumor might spread, and that could be like a risk for recurrence. For that reason, they try to avoid the risk for capsule damage during the dissection of the tumor from the kidney. For that reason, the surgeon usually prefers to do in-plot resection of the retroperitoneal space, including the kidney. They remove the tumor and the kidney at the same time to make sure that the capsule of the tumor is intact. But although this approach has not been proven in clinical trial, that is going to prevent tumor recurrence. And the last important key point that if the first surgery was suboptimal and there's a microscopic incomplete resection, then discussing a repeated surgery in multidisciplinary expert team is doable. Moving to the pathologic evaluation of ACC. Histopathology is the golden standard for diagnosis of ACC. And usually any pathology report for ACC should at least contain the following information, which are the Weiss system score, Ki-67 index, the resection status, and tumor stage. So I just want to go over the Weiss score. So the diagnosis of ACC histologically can be challenging sometimes, and sometimes it's different to differentiate between ACC from benign adenoma. For that reason, there's many classification system based on histology and other numbers of additional marker that can help the pathology to distinguish between benign or malignant adrenocarcinoma tumor. And those are some examples from those score system, but the most widely accepted system adopted by WHO classification is called the WISE criteria, which was published in 1984, which so far is still the best valid score. So this score was established by Dr. Lawrence Weiss, and I think he practiced in California. I'm not sure at which institution. And the purpose of his study was to investigate, do investigation. The purpose of this investigation was to analyze a series of adrenocortical neoplasm to ascertain whether one or a combination of microscopic features can be used as an effective predictor for malignancy. So we had a series of 43 patients with adrenocortical tumor, benign and malignant, and he did histological analysis by using 9 histological features. It's clear. And these 9 histological features are one, the nuclear grades, the mitotic rates of the nuclei, atypical mitosis, cytoplasm feature, the architecture of the tumor, the presence of necrosis, the presence of invasion of the venous structure, the presence of the invasion of the subosodial structure, and if there's any invasion of the capsule. And each feature that presents in the tumor is going to get like 1 grade. And on his finding that he mentioned that all but one of the non-metastatic, non-recurrent tumor, which is the benign tumor, has 2 or less of this 9 criteria, which is mean if the tumor has 2 or less of this criteria, that means this tumor is most likely to be benign. And he mentioned that all metastatic and or recurrent tumor have 4 or greater of this 9 criteria, which is mean if the tumor has 4 or more of this criteria, that means almost certain it's a malignancy. So based on the recommendation that ACC could be diagnosed on the presence of at least 3 of the 9 histologic features. And those 3 that I highlighted this are the most specific one. Because if you look to the study, the presence of mitosis here, about 7 of patients with metastatic cancer present, but 0 in non-recurrent. So that's kind of more specific for cancer. Also, the presence of venous invasion, only present in malignant tumors, but none in the benign tumor. Moving to the second important part of the pathology report is the Ki-67 index. Ki-67 is a nuclear antigen, and it's a good marker for active cell proliferation in both normal and tumor cell, which is mean more the cell is active and proliferating, the Ki-67 is going to be higher. So an index of 10% is considered low, a level of 10 or 20 considered to be high. So this index has been used as a prognostic and a predictive marker for different tumor, and one of them adrenocortical carcinoma, which has been studied as a predictor marker for tumor recurrence after surgery. So this is a study, I think they included almost 319 patients with adrenal cancer, and this is from Germany. And the aim or the goal of the study to see if there's any correlation between clinical, histological, and immunohistochemical markers with the recurrence-free survival and overall survival. And they found that the patient who has a Ki-67 less than 10%, they have the longest free survival and the longer overall survival. With a patient of less than 10% of Ki-67 has a recurrence-free survival of 53 months compared to 31 months and 9.9 months for Ki-67, 10 to 15, 19% and above 20. So they included that identified Ki-67 as a single most important predictor predicting recurrence of inpatient following resection. And as I recall, our patient has a Ki-67 of 55. So that's in his case, was a predictor marker for possible recurrence in the future. Staging for ACC. The staging of ACC based on the European network of the study adrenal tumor and also based on the American Joint Committee of Cancer. And they use the TNM system. And usually stage 1, usually if there's no lymph node metastasis, if there's no distal metastasis with T1, which is mean tumor size less than 5 centimeter, T2, which is consistent with stage 2, tumor size larger more than 5 centimeter. Stage 3 cancer, usually when there's any lymph nodes presence, involvement, or in 2, 3, and T4. T3 means the tumor is growing in the fat that's surrounding the adrenal gland. T3, T4 means the tumor is growing into the nearby organs. Stage 4, only when there's distal metastasis, which has the poor prognostic outcome. Metastasis of ACC, usually the most of them happen to the lung and the liver, about 40 to 80%. So after we discussed surgical approach, the diagnosis following histology approach, then how this patient is going to be followed for the long term after surgery to make sure that the tumor doesn't recur and to make sure we're not missing any metastasis. So also I'm going to highlight some recommendation from the European Society of Endocrinology, looking for the surveillance follow-up after surgery and the role of adjuvant therapy. So usually they recommend after surgery, the best imaging study can be done is a cross-sectional imaging by doing CT scan and MRI of the chest, abdomen, pelvis. And the reason for that, because the majority of this cancer recurrence or progression, majority of the time occur like within local regional, or they only metastasis to the lung and the liver. So doing CT scan involving the chest, abdomen, pelvis is going to cover most of this recurrence or metastasis. Bone metastasis, not frequent, and brain involvement is very rare. And usually they recommend after complete resection of the tumor, they suggest radiological imaging every 3 months for the first 2 years, and after that, every 3 to 6 months for 3 years. But for a patient who has advanced and progressing ACC, then the surveillance is going to be different depending on overall prognosis and the ongoing treatment type, which can vary between 2 to 3 months. But this recommendation as suggestion is just in accordance with the practice at many expert centers and with the standards for other malignancy. But there's no any published clinical study to support this recommendation. Talking now about the adjuvant therapy. Adjuvant therapy means that after the tumor has been resected, we're going to give additional treatments to reduce the risk of cancer recurrence, especially with ACC, because even in complete resection of the ACC tumor, the rate of local recurrence of ACC can range between 19 to 34%, and that's depending on the tumor stage. And also recurrence risk can be higher with the higher Ki-67 index, which is another important prognostic factor predicting recurrence. For that reason, the adjuvant therapy is recommended in patients without microscopic tumor residual after surgery who has high risk for recurrence. High risk for recurrence mean stage 3 cancer, R1 resection. R1 mean that there's some microscopic residual in histology, and if they have Ki-67 above 10%. Those are studied and has been associated with high risk for malignancy in the future. For that reason, adjuvant therapy is recommended. And the most used drug is Mitoten, which is only approved approved by FDA for ACC management. Mitoten is an adrenocytolytic drug. It causes adrenal atrophy by causing destruction for the adrenal cortex. And also it inhibits several enzymes in the steroid synthesis pathway. So far, this is the only approved medication for adjuvant therapy. There's multiple clinical trial has been done to prove the efficacy of mitoten after surgery to reduce the risk of malignancy, and this one's published in Italy about in 2007. And the goal of the study to evaluate the efficacy of adjuvant mitoten in prolonging recurrence-free survival, and they involved 177 patients who had ACC who underwent radical surgery. This or like study from both Italy and Germany. 47 patients received mitoten, and 55 patients from Italy, they have like as a control one, and 57 from Germany as a control two. And from this figure A, as you can see, mitoten therapy was associated with a longer recurrence-free survival compared to the control group. The mitoten group has a median recurrence-free survival as 42 months compared to 2 months on the first control group and 25 months for the second group. And also mitoten group has a median overall survival of 110 months in mitoten group compared to the compared group 52 months and 67 months. So they concluded that adjuvant mitoten may prolong recurrence-free survival in a patient who had radical tumor resection. So although mitoten usually prescribed by oncology and they initiate and titrate the dose, I'm just going to highlight some important point here that mitoten plasma, when started, the level should be reassessed every 3 to 4 weeks until it reaches the plasma concentration target, which is between 14 to 20 milligram per deciliter. And once mitoten plasma level has been reached the plateau, usually the levels can be rechecked every 6 to 12 weeks. And usually in patient without any tumor recurrence who's tolerating mitoten, usually the suggested duration for treatment is at least 2 years, but no longer than 5 years. But the disadvantage of mitoten, although it can help to reduce tumor recurrence rate, it has side effects, and the side effects could be a limiting factor for the patient to continue the treatment and limiting factor to approach the therapeutic dose, because those side effects could happen once the mitoten reach a higher plasma level. And the most side effects are GI side effects like nausea, vomiting, anorexia, CNS side effects like lethargy, insomnolence, vertigo, ataxia, which has happened with higher plasma mitoten. And it could cause like liver damage, gynecomastia, hypogonadism in males, skin rash, some changes in bleeding time, and leukopenia. But from endocrine point, there's 3 or 4 important toxicity associated with mitoten could involve the endocrine and the metabolic system. One of them, the adrenal function. Since mitoten inhibits multiple enzyme steps in the steroidogenesis and has a direct toxic effect on adrenal cortex, therefore adrenal insufficiency should be considered as an expected event during therapy. And usually the cortisol level usually decline after 3 months of therapy. And I'm assuming, and I'm kind of sure that oncology, usually they start patient on steroid replacement therapy right away from the beginning. They don't wait for adrenal insufficiency to happen because that's very high incidence rate. And usually the total daily dose of hydrocortisone somewhere between 40 to 50 milligram, which is higher compared to like a regular maintenance dose for a patient with other causes for adrenal insufficiency. I think I'm missing a slide here because this is 2, then it goes. Let's go to 3. I think I'm missing a slide, which is about thyroids. Mitoten also could known to affect the thyroid function test. And what happens for that reason, the thyroid function test should be assessed at least every 3 months, because it's about 30 to 40% of the patient. What happens when they do the blood work, they find it associated with low free T4, but normal TSH and free T3. Although the etiology for this hypothyroidism is not very clear, but it looks like the mitoten has a direct toxicity to the pituitary, and it gives us kind of like some clinical picture similar to like central hypogonadism with low free T4 with normal TSH. So they recommend to check thyroid function test every 3 months and start treatment if needed. And then the third part is male hypogonadism symptoms and gynecomastia. About 30 to 35% of the patients after 3 months, they may develop the side effect after treatment. And biochemical evaluation, it's going to show significant decline in free T4, but not that much significant increase in total total testosterone level, and increase in the sex hormone binding globulin, but no change in FSH and LH. And the proposed etiology for that, the increase in sex hormone binding globulin synthesis is going to lead to more reduction in the free testosterone level. And another metabolic toxicity related to, or side effect related to myostatin is dyslipidemia. Myostatin is known to cause about 50% of the patient to have increase in LDL, HDL, and triglyceride level. And this is a study from MD Anderson back in 2013, and they investigate the baseline lipid panel before and after static myostatin. So looking to HDL, they have a patient, they're looking into about 40 patients. The baseline HDL before therapy was 53 and increased to 83 after therapy, which is at least 1 month after therapy. Also, the LDL increased from baseline 114 to 160. Triglyceride also increased from baseline 149 to 216. And usually the treatment for patient who needs indicated is statin. But this is the expected side effect from myostatin. So this is like a table which is kind of summarize the kind of blood work and hormone evaluation while monitoring during myostatin therapy. So as we discussed before, myostatin can have a major role in prevents tumor recurrence, but unfortunately, if the patients develop recurrence or they develop metastasis while on myostatin, then the second step is to add cytotoxic drug, EDPO, etoposide, doxorubicin, and cisplatin. But usually if the patients progress while on myostatin, usually the prognosis is poor because so far there's no kind of drug has been found proven that it can stop the tumor progression. So for this patient who usually progress ACC, usually the prognosis is poor, and patient who has widespread metastasis disease, usually at the first diagnosis, usually they suggest possibly avoid surgery and go into more palliative treatments. So the last part of the presentation and to look into 4 direction in ACC management. As we discussed, given the aggressive behavior of ACC and high mortality rate, especially with advanced ACC and limited clinical response to the best available therapy so far, identifying new therapeutic targets for treatment and options for treatment are really needed. So I'm just going to go over some of the targeted and immunotherapy that has been tried so far. One of them is the targeted antibodies. Target antibodies are antibodies that usually bind to the tumor cell surface directly, and it's block certain molecular pathway and usually lead to cell death. Based on the preclinical data, usually shown in the past that about 90% of ACC overexpress IGF-2, and several clinical trials has been conducted using monoclonal antibodies to try to inhibit IGF-2 receptor and IGF-1 receptor. And the one that has been studied, all of them has been studied, but none of which has seen any promising effect. This is a study, I think it was done in 2015, looking to one of them is called lecitinib, and the goal of which is a small molecule to inhibit both IGF-1 and insulin receptor. And they tried it on 149 patients, and 90 patients who got the treatment and 49 got a placebo. But as a result, there was no difference in overall survival between 2 groups. And so it was not kind of very, very promising study. Another treatment has been tried is monoclonal antibodies and checkpoint inhibitor, which has been used in different malignancy and has been shown positive outcome. But for that reason, there was kind of interest to see if that benefit also applied for ACC patients. So there's data from different clinical trial using single immunocheckpoint inhibitor, and sometimes they use like a two immunocheckpoint inhibitor to try to see if there's any effect on ACC patients. This is one of the first clinical trial has been tried for immunocheckpoint for avelumab, and this is back in 2018 in France. And they tried it for about 50 patients. And as we can see, 25 of the patient was already on mitoten, 25 was not on mitoten. And they established, and they followed this patient for approximately like 16 to 20 months. And disease stability was achieved on about 40% of the patients. But the disease progressed in about 40 to 50% of the patients. None of the patient has any complete response. Another one, nivolumab, also has been tried, and also in a small clinical trial about in 10 patients only. Again, no complete response, 0 patient responded, 7 patients progressed, 2 patients only had stable disease. So they concluded that nivolumab has modest anti-tumor activity in patients with advanced ACC. But I don't know if it's like modest. I don't consider it as a modest. Not very promising. Also, pembrolizumab as well has been tried. In this clinical trial in 2020, they tried pembrolizumab Keytruda every 4 weeks. But again, complete response on 39 patients was 0%, partial response about 23%, stable disease 80%, but about 38% of those patients progress. Another study about for pembrolizumab as well. This from MD Anderson in 2019, and they tried it on about 16 patients, 14 only completed the study, and the best response was about 5 patients of this patients, 5 of 16 patients, they had no progression rate for 27 weeks. So this is like a list of about 1, 2, 3, 4, 5, 6, 7 different clinical trial using monoclonal antibodies as checkpoint inhibitor, as a monotherapy, combined therapy. They tried it with tyrosine kinase, levodopa as well, but none of them has shown any complete tumor response. Other immunotherapy has been tried, is called immunomodulator, which is it's like a class of active immunotherapy, which is usually work on the tumor to work on the T cell to activate it and to activate the natural killer cell to work in the tumors. A cell try to cause tumor cell destruction. And multiple have been tried, and one of them is thalidomide, which is tried on 27 patients in Germany in 2019, but the best response for the treatment was disease stability in 2 patients only. 25 patients, they progress, and the progression-free survival was 11 weeks, and overall survival rate was 36. So also that's promising. Tyrosine kinase also has been studied. Usually there's approved for patients with medullary thyroid cancer, also has been approved for renal cancer, has been tried for ACC, but also not that promising results. This is a study from Germany in 2020, and they tried it on 16 patients. And also the best response was partial response in 3 patients, stable disease in 5 patients, but 8 patients, they progress over time. And the last one I'm going to mention is the newest one is called cell cycle inhibitor, CDK4, which is cyclin dependent kinase inhibitor. Cycle cell is usually controlled by different key protein, and one of them is called cyclin dependent kinase. And one medicine is called palbociclib, which is a CD4 and 6 inhibitor, which has been approved for management for locally advanced and metastatic breast cancer. And this medicine tried to inhibit the cell cycle pathway. So far, there's ongoing in vitro trial for ACC, but not been tried on patients yet. So that's one of the ongoing trial for newer approach for ACC. But again, what I've read, I've not seen any treatment so far as able to stop the progression of ACC once it happens. So that's gonna come to the end of my presentation. Thank you for your attention and I'd like to hear your questions. He was started on mitoten and also he was started on plus chemotherapy, APD at the same time. Correct. And he's been on treatment for almost 3 months and I'm following him every once in a while just to see how things goes. And his plan to go to get like a CT scan to see if there's recurrence. In his case, the adjuvant therapy was decided to do mainly because of his high Ki-67, more than 55%, which is a high chance for recurrence. For that reason, the decision was to go for mitoten plus cytotoxic therapy. Correct. Plus he's on hydrocortisone. We're trying to monitor testosterone level, lipid panel, and thyroid function tests during treatments.
What are your thoughts on why ACC is such a tricky cancer to treat successfully?
And I think the reason for that, they discussed it in the beginning of my presentation, where I'd go over the pan-genomic analysis and molecular and genomic changes in this tumor. And it looks like there's very heterogeneous. There's a lot of things going on at the same time, a lot of gene changes, alteration in DNA. So there's no like one specific cause of it. There's multiple things going on. So the tumor is very heterogeneous and it's a pathogenesis. So I think that's one of the reasons there's no like specific one target treatment to control it. Yeah. And I think that's what they're trying to initially to look into the IGF-1, IGF-2 receptor because it runs very expressive. About 90% of this patient has overexpression of the IGF-2 genes. So they tried to target it in different medication, but it was not helpful in suppress the tumor. So it looks like there's other things going on at the same time. Correct. Just go to the chat.
There are questions in the chat.
Yes. Is there any specific natural immunity to ACC antigen progress for a long term? Is there natural immunity to ACC antigens? Is there any specific natural immunity to ACC antigens progressed for a long time? I'm not sure if I understood the question. Natural immunity.
If someone has ACC for a long time, is there any antibody response to the specific for ACC antigens different from the benign myelolipoma or something like that?
So if there's any specific immune antigen response to the ACC, I haven't seen that.
Specific antibody response.
Specific antibody response, natural immunobody response to the cancer cell. I've not seen any research that look into that. What they're trying to see if there's any specific antigen in the cancer they can be used to develop antibody against it. But I've not seen any natural developing of antibodies against ACC antigen.
Yes, because they have developed against prostate cancer specific prostate antigens that are only produced by prostate cancer cells, but not by normal prostate cells. So something similar could be developed for ACC. I have two other questions before that.
Yeah, right.
They're kind of a little bit descriptive, but you can check on those.
Okay,
Thanks.
yeah. Could a right adrenal 5 centimeter myelolipoma by CT scan, which when removed by complete adrenal removal by laparoscopic surgery and found by staging to be benign, could it have progressed to ACC if allowed to progress to be larger in a baby boomer? So if myelolipoma, usually they are benign tumor, and usually resection for myelolipoma, if doesn't give any compression symptoms, not symptomatic, usually we don't recommend to remove them. So for that reason, I don't think there's those tumor, if not removed, they're gonna progress later on to ACC.
But on the other hand, you don't know whether that mass is benign or not. So
Correct.
That's why it gets removed and then staged. And when it
Correct.
is staged, it turns out benign, it's fine. But if it was allowed to keep growing into a larger, could it have transitioned to ACC?
Okay, so for myelolipoma, if it's allowed to grow, I don't think it's going to transition to ACC. I don't think there's any case report or any clinical study has been shown that myelolipoma is going to progress to ACC. If myelolipoma is going to progress in size, mainly the reason to remove it is just because of the size and giving symptoms. But I've not come to encounter any clinical study or any case report for myelolipoma to progress to ACC.
Anyway, in the case that I knew that only after staging it was found that it is benign. So one is taking a chance to let it grow and
Correct.
not know it is ACC.
Correct. For that reason, all the endocrine society, they recommend for any adrenal mass above 6 centimeter, it must be removed because you don't want to take a chance to miss adrenal cancer.
Yeah,
Correct.
that's correct. So I think that's a good, and insurance will pay for something after it reaches 6 centimeters. And so it's probably a decision to go ahead and do that rather than treat the symptoms of the mass. Okay, so that was one question. And then
Okay.
what I was trying to say is, are there significant differences in symptoms?
Symptoms of localized benign myelolipoma mass and ACC in terms of hypertension and chromophene level, and is it important to get rid of benign adrenal myelolipoma surgically after it was grow to a certain size when insurance pays for its removal, or let grow to a larger mass and treat it for symptoms? So regarding your question about myelolipoma, if one let it grow, as I said, myelolipoma, it's not 100%, it's benign. There's no reason to remove it unless it's been causing symptoms, which is symptoms consistent with mass-related symptoms like abdominal pain, discomforts, early satiety. In those situations, removal of the myelolipoma is reasonable. Regarding the localized benign myelolipoma, mass effect and ACC in terms of hypertension and chromophene level. So I don't think there's any difference regarding mass effect between myelolipoma and ACC regarding mass effect, unless ACC it's progress and invades surrounding organs like IBC may cause bleeding. It may affect the diaphragm, and it may affect also the liver. So the only mass effect is just the tumor invasion to the surrounding organs, which doesn't happen in myelolipoma.
Thank you.
Thank you for your questions.
Thank you, Zach. And I wanted to add to what Dr. Sibai just said. Dr. Kotwal, myelolipomas can grow up to 20, 25, in the case reports, up to even 30 centimeters, benign. But like he said, the only reason to remove them is because of the symptoms related to nephroptosis or compression on IVC or such. But they're extremely benign usually and do not need to be removed if there's no compression or symptoms related to the size. So,
but like Dr. Sibai said, it is sometimes you're taking a chance. You don't know whether that until it has been removed and staged, you don't know whether it was benign or it was ACC.
Usually myelolipoma, it's can be differentiated from ACC by imaging study. Imaging study is very helpful to differentiate between ACC and myelolipoma. Myelolipoma usually looks different on CT scan, and radiology can able to identify it and compare it from ACC, from cancer.
That must be a recent advances because 8 years ago that wasn't the case. It was very difficult to differentiate until it was removed and staged.
Okay. That's pretty classic on imaging phenotype. Thank you, Zach.
Yeah, thank you, Dr. Krish. And thank you, everyone. And have a nice evening.